Dr. Sam. Can you hear me?
Yes, it's okay. Go ahead.
Okay. Uh, so, ladies and gentlemen, I am Minji from the Department of Neurosurgery of Huashan Hospital. It's my great honor to be here presenting my current work about lung cancer brain metastases. My talk today will be divided into three parts. As we all know, lung cancer stands as the leading cause of cancer-related deaths, with up to 40 to 50% developing metastasis in the central nervous system, either during the initial diagnosis or during the progression course. The presence of CNS metastasis predicts a poor prognosis, either in terms of survival or response to systematic therapies. Uh, Receptor tyrosine kinase mutations are often driving events in non-small cell lung cancer tumorigenesis that carry important diagnostic value. The systematic characterization of RTK mutations like EGFR, ALK, KRAS, and so on empowered a new era of cancer therapies shaped by the personalized targeted medicine, especially the TKI. Osimertinib was approved as a standard first-line treatment for the lung cancer brain metastases harboring EGFR mutations because of its outstanding CNS penetration and could inhibit the acquired EGFR mutations which are resistant to the first or second generation TKI. However, TKI resistance is still inevitable even with osimertinib. Multiple mechanisms mediate TKI resistance as reported, like the metabolism reprogramming, suppressive tumor microenvironment, and other mechanisms. So combining TKI and the immune therapy might offer new hope for treating the lung cancer brain metastases. While targeted therapy remains the backbone of medical therapy for lung cancer, the development of immune checkpoint blockade have conferred an overall survival advantage for brain metastases patients. However, the efficacy of anti-PD-1 or anti-PD-L1 is minimal in EGFR or ALK mutant patients to date. We next asked whether other ICB reagents could help, like anti-CTLA-4, TIM3, or anti-LAG3. So in the end of this presentation, I'm sure you could get the answer. Total, we want to figure out three questions. That is, whether TKI could remodel the TME in lung cancer brain metastases. Secondly, how could the TME re-architecture contribute to TKI resistance? Thirdly, could ICB and the TKI combination could alleviate TKI resistance? To this end, we collected a total of 12 resected lung cancer brain metastases samples for single-cell RNA sequencing, which is an ideal tool to monitor the TME features. Meanwhile, to validate the computational results from single-cell RNA-seq, we retrospectively assembled more than 100 FFPE specimens for Monte-Carlo IHC staining as a validation cohort. We identified 8 major cell lineages. Notably, the immune cells consist of different kinds, including the T cells, NK cells, B cells, and the myeloid cells. The infiltration of T cells consists of almost 1/4 within the TME. This finding refutes the historic view of that brain is an immune privileged organ, and the brain tumor is so-called cold tumor. We conducted IH staining to further compare the T cell infiltration among the primary and metastatic lung cancer, as well as glioma, the most common primary brain tumor. Remarkably, lung cancer brain metastases exhibit significantly higher infiltration level of T cells compared to the glioma. Meanwhile, we also observed the high heterogeneity within the lung cancer brain metastases. We found the KRAS mutant or TP53 mutant tumors exhibit a higher level of lung cancer of T cell infiltration compared to those with EGFR or ALK mutations. So we hypothesized that the EGFR or ALK mutations specifically linked to the T cell insufficiency in lung cancer brain metastases. Interestingly, TKI administration could reverse the T cell deficiency in EGFR mutant or ALK mutant metastatic lung cancer. We further examined that the detailed compositional changes in the T cells and found CD8 positive cytotoxic T cells and CD4 positive Treg cells significantly increased after the TKI treatments. The molecular IHC staining results also corroborate the results from the computational analysis. Since the CD8 T cells are considered as an pro-inflammatory subset and the CD4 Treg is believed to contribute to the immune suppression, it seems confusing that TKI increased two groups of T cells with totally opposite functions. This contradiction also promoted us to investigate how could TKI treatment regulate T cell function. We performed the pseudo-time analysis via molecular tool and identified a trajectory that encompassed most TKI-treated T cells. We found in the late stage of TKI-treated specific trajectory, an classic checkpoint CTLA4 expression could be upregulated. To test if other checkpoints could also be amplified upon TKI treatment, we analyzed other immune checkpoint expression besides CTLA4, such as PDCD1 encoding PD1, HAVCR2 encoding TIM3 and LAG3. While CTLA4 was predominantly upregulated after TKI administration, other co-inhibitory receptors were either decreased or slightly increased after TKI treatment. These findings suggest CTLA4 might be the core molecule mediating the TKI resistance. To validate our observations, we next established the murine model to ascertain the in vivo function of TKI comprehensively. Therefore, we generated the luciferins labeled LLC cells that carrying EGFR mutations, which represented the TKI sensitizing mutations. We found osimertinib could efficiently inhibit the phosphorylation of ERK, which is a very important downstream pathway of EGFR activation. After that, we injected the cells intracerebrally, which could form brain metastases a month later, as shown on the right. The in vivo imaging showed that osimertinib could significantly retarded intracranial tumor growth. More importantly, TKI significantly extended survival compared to their naive counterparts. Mimicking our finding in human samples, osimertinib could also upregulate the CTLA4 expression in cells as depicted by the IHC staining. To test that the hypothesis that CTLA4 is the core molecule in the process of TKI resistance, we investigated whether a combination of anti-CTLA-4 and TKI treatment could uh, overcome the TKI resistance. As expected, the co-treatment of anti-CTLA-4 and osimertinib significantly reduced the tumor burden of lung cancer brain metastases and could also extend the survival significantly. We also collected the whole brain at 4 different time points, which enable us to monitor the dynamic evolution during the combined therapy. Further analysis suggests the antibody-mediated effects could reprogram the T cell transcriptomic programs and enhance the cytotoxic T cell activation. So this is our working model. In conclusion, this study refutes the oversimplified view of TKI resistance and equal anew from the perspective of extrinsic immune escape. Firstly, we found the TME in lung cancer brain metastases exhibits high heterogeneity, while the EGFR and ALK mutant lung cancer brain metastases could exhibit T cell deficiency. And interestingly, TKI could restore the T cell deficiency in lung cancer brain metastases, but unfortunately, the increased T cells is dysfunction due to the upregulation of CTLA-4. So we combined this anti-CTLA-4 and the TKI to alleviate the TKI resistance, and as expected, this combination therapy could indeed extend the survival. In the end, I would like to express my appreciation to Dr. Mao and Dr. Hua and Dr. Chi for their invaluable insights and the patient's guidance throughout this study. Thank you for your listening. If you have any question about the topic today, feel free to contact me. My email address is shown below. That's all. Thank you.
Thank you, Dr. Minji, for this excellent presentation.